Hello, and thank you for your patience. Thank you for joining us for this webinar. We're excited to get started. The webinar is Prostate Cancer Breakthroughs, Updates from the 2025 American Society of Clinical Oncology Annual Meeting. My name is Jeremy Patch, Senior Director of Patient Programs and Education here at Zero Prostate Cancer, and I'll be serving as your host. I'm excited for you to hear from our esteemed featured speaker, Dr. Alicia Morgans, joining us shortly. I'd like to share just a few notes before we get started. Today's webinar, as always, is being recorded and will be posted on our website, zerocancer.org, later this week. Closed captioning is available at the bottom of the Zoom window. Look for the two CCs in a box and select Show Captions. As soon as the event ends, you'll see a link to a survey. We want to hear your feedback. So on this event and on topics you'd like to have covered in future educational programs. So please take that survey when you see it. Tomorrow, you will also receive an email with a link to the recording location and the survey. We asked for question submissions ahead of this webinar, and we have many great questions that have come in and that we'll cover after the presentation. We'll do our best to get to as many of those as possible. Remember, neither Zero nor guest speakers can provide individual medical advice, so please, we'll try to keep those questions general. I'd first like to thank our webinar series sponsors, Boston Scientific and Foundation Medicine. Their generous support makes events like this possible. And Zero Prostate Cancer, I'm happy to show our new mission and vision that are relatively new, came out a few months ago. Zero's on a mission to improve and save lives from prostate cancer through advocacy, education, awareness, and support. Our vision is a future where prostate cancer detection is early, support is unwavering, and care is accessible to all. And we live out that mission through really our programs and our educational events like tonight's webinar. So we're proud to offer a variety of free patient support programs and educational tools. If you or someone you know needs resources at any time while facing prostate cancer, please share these tools. These programs offer relief and a chance to connect with others who are experiencing many of the same things you are as a patient, a survivor, or a caregiver. I'll just briefly go through these. 0360 provides case management to help patients and their families navigate insurance and connect with financial assistance and emotional support programs. So if you or someone you know has had an insurance denial and you're wondering what to do, if you have a bill that you can't pay, if you're wondering how to get connected to a food pantry in your area, 0360 case managers can help with those types of things and many more. We offer two peer support programs. Our mentor program makes one-on-one connections. So a trained patient or survivor, largely helping those newly diagnosed or anyone along their journey. And then our support groups are offered virtually and in person across the country. So two options there for what fits you. And if you prefer online support, you can connect with others affected by prostate cancer in Zero Connect. That's our private Facebook group, or on our prostate cancer forum empowered by Inspire. So those are other great options to get questions answered. And often just, I think people post questions like, what to expect after I've had surgery, or, going on ADT in a month. What advice can you give me? Those types of things are often shared there. Before we continue, I want to remind everyone that this webinar is being recorded and will be available later on our website, zerocancer.org. Now, please join me in welcoming Dr. Alicia Morgans, Associate Professor of Medicine at Harvard Medical School. She's a genitourinary medical oncologist and Director of the Survivorship Program at the Dana-Farber Cancer Institute Medical Center. We are fortunate to have her also as the chair of Zero's Medical Advisory Board. Thank you for being here, Dr. Morgans. It's my pleasure to turn it over to you.
Well, thank you. Thank you so much, Jeremy. And thank you, everybody, for being here. I'm going to take a minute and share my screen here so we can get some slides up. And I am really, really pleased that so many people have come out this evening to think about and talk about prostate cancer. I would just add that I think it's great also that this is going to be recorded, so this can be something that people can watch later, or if people have missed it, it's an opportunity. I know that the real goal here is to do updates associated with ASCO, which is our annual oncology meeting. It's actually for all cancer types, with a focus mostly on solid tumors like prostate cancer and lung cancer and colon cancer, but also some information also on leukemia, lymphoma, and some of those liquid cancers. But in order to be maximally effective, the slides I've prepared are basically updates and strategies, kind of key thoughts for people with prostate cancer over the last few years, because so much progress has been made. I wanted to include more than just updates from ASCO. These are my disclosures, and if there's interest, I'm sure that we can make sure that we share some of these slides in the future as well, including the disclosures slide. This is the outline of what we'll talk about. Just a moment on prostate cancer as an entity. Sorry, the slides seem to be advancing a little faster than I expect, so apologies if I have to go back. But some slides, you know what, while we're doing this, I'm going to stop sharing everybody for just a moment. And I think sometimes there's a setting on these that may be set, and I'm just going to clear that, and we will start again. Sorry about that, but I think it'll make it better for all of us if the slides are not jumping forward throughout this meeting. All right, perfect. So a minute on prostate cancer background, and then a moment to mention kind of strategies and really standard approaches for people with newly diagnosed metastatic prostate cancer. Then a comment and discussion a little bit on genetic testing and the types of genetic testing. Then we'll talk about some of the updates around treatments that target some of the mutations that we look for with genetic testing, including PARP inhibitors and combinations with PARP inhibitors, as well as immunotherapy. And then we'll briefly touch on radiopharmaceuticals or radioligand therapy. These are radioactive medicines that have become more and more prevalent in our treatment options, and certainly have been advances at multiple recent meetings, including ASCO. And then I'll sum it up at the end. And I think importantly, we're going to have a lot of time to review and discuss questions that you may have. So this slide is a basic representation of the way that doctors think about the stages of prostate cancer. If you are thinking, this looks really complicated and is kind of messy and has a lot of words written all over it, you are right. All of those things are true. It is really complicated, and it's only becoming more complicated. And that's a good thing for patients. It's a good thing for doctors, and certainly a good thing for family members, because the reason it's becoming so complicated is that we in the cancer care community, taking care of people with prostate cancer, and scientists are really working to understand specifics about different states and phases of prostate cancer, and the way that different treatments might be harnessed to target certain vulnerabilities in different ways across the spectrum of the different stages of prostate cancer. On the left-hand side of the screen, you can see the localized prostate cancer, which is the way we talk about or label prostate cancer that is all still in the prostate. Most people are actually still diagnosed with prostate cancer that is all still within the prostate, localized prostate cancer. And this is because PSA screening, the blood test that helps us understand that there may be a prostate cancer brewing in a person who does not have any symptoms, this PSA screening helps us identify prostate cancer often in an earlier state when it's localized. And the important thing about localized prostate cancer is that we use treatments like surgery or radiation cancer to really cure the prostate cancer or monitor it and never treat it if it's not something that needs to be treated. When we look in the middle, we can see that after localized prostate cancer, there's a setting called biochemical recurrence. This is where we might see recurrence or the cancer's coming back, often identified first because the PSA starts to rise, even though someone has already been treated. This is a setting where we have some new therapeutic developments as well. Then we get into the middle part of the slide where we're really talking about people who have metastatic prostate cancer. There are many words written in black above the boxes that show the states of prostate cancer here because there are many treatments and combinations of treatments that we use in this metastatic setting when the prostate cancer has moved outside of the prostate into lymph nodes, bone, or other areas of the body. And there is a lot of treatment development that's happening in that area and a lot of investigation that's ongoing. And then across the phase of orange boxes, moving over to the right-hand side of this slide, this is after the cancer has been treated and is starting to develop some resistance. We still have many different treatments and are developing many more to potentially use in these settings, even in areas that are more nuanced and targeted. And each trial that we design is helping us to understand some of the specifics of an individual's prostate cancer, even in these most advanced settings, to provide personalized treatments that may be most effective for that individual. So the message of this slide is that there are lots of states and lots of phases of a prostate cancer diagnosis, from something that might be all within the prostate and curable to something that's been treated and spread and is now more resistant, but still has treatment options. And I think it's important to recognize that the treatments that we recommend have to be really tailored and studied in each of these different states to make sure that that's the right thing for the person. And so a treatment that might be perfect and helpful in one state may not be used in another state for scientific reasons or because the data simply isn't there, that it hasn't been studied for use in that setting. And so it's important to have conversations with your doctor, recognizing that each state has its own treatment for it, and that clinical trials are happening across this spectrum to try to advance the way that we treat prostate cancer overall. So let's dive in to metastatic hormone-sensitive prostate cancer. So what is that? Let me just get a definition out of the way here. Metastatic, of course, is what we just talked about, that being prostate cancer that has spread outside of the prostate. That's metastatic. It could be metastatic to lymph nodes near the prostate, to lymph nodes far from the prostate, to liver, to lungs, to bones, to other places. But if it's outside of the prostate, it's technically metastatic, meaning it has spread. Hormone sensitive means that this is a prostate cancer that has not yet received treatment. And most of the treatments that we have are all centered around the idea that the main fuel, the food, or the driving force for prostate cancer cells is testosterone, that male hormone. And when those cells are activated by testosterone, they are really energized and stimulated. They can grow, they can spread, they can move and do things that we don't want them to do. And we want at all costs to starve them at this point in time of our knowledge, starve them of testosterone, really make them weak, make them vulnerable, stop them from spreading, dividing, growing, and make them so weak that hopefully some of them will starve to death, or that our other treatments will be better able to kill them. So we use hormonal treatments that starve them of the hormone testosterone. And hormone sensitive prostate cancer is a cancer that has not yet seen that treatment, is not resistant, is sensitive to that type of treatment, and is really just starting off in terms of its initial care and in the metastatic or spread setting. The main message here is written right underneath that label. Patients need more than just ADT, and I'll go through some of the reasons why. First of all, what is ADT? ADT stands for androgen deprivation therapy. This is treatment that lowers testosterone in a person's body, again, to starve the cancer cells. It's the backbone of all that we do. I would say that a lot of the trials that are currently being launched and are ongoing are trying to limit us from having to decrease testosterone, because we know that comes with side effects. And if we can get around that and we don't have to limit testosterone, that would be great. That would be an area of interest. So we are investigating. But right now, we lower testosterone through ADT, androgen deprivation therapy. And the message here is you need more than just a medicine that lowers your testosterone. You need something added to it. And many studies, including presentations at GU ASCO, have reiterated and reinforced that message. So let's look at some of the studies. These are just labels on the left, labels of clinical trials. In the middle, it says intervention. This is all the stuff that was done in addition to ADT. You can see all the things that are there, plus ADT, that backbone of lowering testosterone. And then the comments column all the way on the right, for all of these trials shows a benefit to adding the thing to ADT. The control arm in a clinical trial is the standard, basically the standard comparison arm. It's the thing that's been the way that we've done things. And the intervention arm, as you can see, is something that's, in this case, added to that standard of care to see if we can do even better. In some clinical trials, we actually take something away from the control to see if we're over-treating people and we can do just as well by doing less. But in these trials, everything has been an addition to the control of ADT. And in this case, we can see that whether we add radiation to the prostate for people with lower amounts of metastatic prostate cancer, whether we add chemotherapy like docetaxel chemotherapy, whether we add hormone pathway targeting agents like abiraterone, which decreases testosterone production from our adrenal glands, enzalutamide, which blocks testosterone from getting into the cancer cell, or apalutamide, which also blocks testosterone from getting into the cancer cell, or darolutamide plus docetaxel, or without docetaxel plus ADT. These are all things, these additions all benefit the person. However we slice it, we're benefiting the person when we add something to that backbone of ADT. So another part of the primer here to talk about tonight is making sure that everybody understands what a survival curve means and how to interpret that, because oncologists, urologists, we all use these things called survival curves to try to understand the difference between two treatments. And if you're not looking at these often and a doctor shows you, oh, well, the curve shows that this one is clearly better, I think it can be a little complicated and difficult to understand. Whereas, if we look at these all the time, every day, it's very intuitive by the time you get a lot of practice and look at these. So to talk this through and to interpret what I may show you in a few slides on some different comparisons of these different treatments with the control arms, let's talk this through. So in any of these curves, time goes from left to right on this graph. And here we can see I've drawn a little arrow that shows time, starting from time 0 at the lower left-hand corner and extending in this graph here in days to day 1000. So over time, you can see that time is going from left to right. The number, or the percent of people alive, is on the vertical axis. And the closer to the top of that axis you get, the more people are alive. I'm so sorry. Joshua, can you get out of here, please? Okay. Sorry, I've got an active dog and a 15-year-old or almost 15-year-old who have come in to learn more about prostate cancer. So we will continue on. The number of people alive is on the vertical axis. And the closer to the top of that axis, the more people are alive. So here we can see more people alive being at the top. So time goes from left to right, and people at the top left corner it's 100% of people alive. So if we go from left to right, time is passing and people are passing away over time, which is something that happens if we follow populations of people no matter what. But in a prostate cancer population, obviously this is going to happen over time. When we look at this over time, again, as the line goes downwards, this is showing people passing away or people surviving, depending on which side you're looking at. The space between these two lines, and these two lines represent the two different treatments, treatment A in this case in blue and treatment B in red. The space between these two lines shows that the treatments are different. There's a different rate of falling over time, a different rate of people passing away over time in this curve. And with every survival curve, the one that is on the top, in this case, treatment A in blue, is the better one. So whenever you're looking at these curves, the one that ends up being, if they're separated, the one that's on the top is going to be the one that's better. The one that's on the bottom is the one that's worse. The difference between the two lines is going to be the amount of difference between two treatments and the benefit that they have. Now, if these two treatment lines are completely overlapping, then there's no difference between the treatments. And that shows you that whatever you've done in your experimental treatment is not better than the original treatment. It's also not worse if they're overlapping. And sometimes the treatment that you're trying is actually worse than the treatment that you had before. And then that line for the new treatment is going to be below. The one on the top is always the one that's better. Treatment A is better. So let's look a little bit at some of this information. Here we can see information from one of the trials that I talked about earlier, where we add something to that ADT backbone of lowering testosterone to see if we can do better and improve survival for people with prostate cancer. In this situation, this study is looking at three drugs together: ADT, chemotherapy, which is also called docetaxel in this setting, and abiraterone, a medicine that stops the adrenal glands from making testosterone. And when we add these three things together, we know that it's labeled SOC plus abiraterone in this drawing. We know that that is better than SOC, or standard of care, which in this case is ADT and docetaxel chemotherapy alone. The difference between these two lines represent how much better. And it looks like it's reducing mortality by about half. And you can tell that, or at least in this case, sorry, progression, not mortality. It's reducing the number of people who have cancer growing on scans by half over time. And you know that because of the number 0.5 here in hazard ratio. But you don't need to know all of that. Just look in general. You can see the lines are separating. The one on the top is better, is slowing down the cancer's growth when we add those extra medicines on. And in this case, that's abiraterone. So the bottom line on this slide is if you have ADT and metastatic prostate cancer and you add stuff to it, you're going to do better than ADT alone, which is a key and main message in this point. Also importantly, when we're thinking about adding stuff on, I think it's really important that we know which patients may benefit the most. When it comes to chemotherapy, the amount of cancer burden that somebody has is one of the advances that we've learned. With less cancer burden, chemotherapy may be less helpful, and that is demonstrated with the figure in the middle. You see the lines overlapping, so there's no real difference between those curves. And that's the population who has less cancer that has spread outside of the prostate. On the right-hand figure, lines are separating. That's a group of people who have a large amount of cancer that's spread outside of the prostate. So in this setting, we can see that chemotherapy, which is what is different between the two treatment arms, is really seeming to be more effective in patients who have more cancer in their system. Here's another one of those triple therapies. This is for people who are going to be fitter, who can take chemotherapy. The triple therapies at this point in time all include chemotherapy, docetaxel chemotherapy. And in this setting, we can see darolutamide, which is one of our newer testosterone blocking drugs, when added to ADT and chemotherapy, separates those lines and gives us a benefit. So that's going to be a consistent story here. We add something on here in addition to ADT, we're going to do better. Importantly, in that study, most of these patients also had more aggressive cancer. This is what we call, one of the ways we know that someone has more aggressive cancer is if it is metastatic at the first time that it's diagnosed. So more aggressive features include being metastatic at that first time that that person's diagnosed with cancer, or spread outside of the prostate at that first time that they're diagnosed. And also if people have more cancer that has spread outside of the prostate. Those are two signs of being more aggressive, and those are two characteristics that seem to be associated with people having more benefit from adding chemotherapy. Why is it so important that we think about benefit, particularly with chemotherapy? It's because if we're going to add chemotherapy, which can have more side effects, we want to make sure that there is a purpose that's a positive purpose to adding that chemotherapy. We want to get a benefit for the patient if they're going to have more side effects. And in this case, we know that the people that benefit the most are the people who have the most aggressive cancer, if it's metastatic at diagnosis, and is a larger amount of metastatic disease rather than a small amount. So the conclusions here are shown. I showed you the table, and then I showed you just a couple of studies because I don't want to go into every study, but we saw there was a table demonstrating lots of people benefiting when they add something onto that backbone of ADT. So metastatic prostate cancer, new diagnosis, hormone sensitive, ADT combinations. Add something to that ADT, that's the new standard. You can use a triplet that includes chemotherapy plus a hormone type pill, like one that blocks the testosterone from getting into the prostate cancer cell, or that abiraterone that turns off the adrenal glands from making testosterone. You could add those with the chemotherapy. if you have a more aggressive metastatic cancer, large amounts of metastatic cancer, or if the person just says, hey, I want to be more aggressive, give me 3 things instead of 2, then you have that option. But if you have somebody who is older, maybe more frail, or they only have a small amount of cancer, and maybe that cancer came back after they already had a prostate removal or radiation, then that's a situation where maybe you just use the hormone pill that blocks the cancer from getting the testosterone and the ADT backbone that turns off testosterone production for the person. Just a doublet combination maybe. But everybody should get something with their ADT. So if you have a new diagnosis or you know someone who has a new diagnosis of prostate cancer that's spread outside of the prostate, they need to have ADT plus a partner. Everybody gets ADT plus a partner, or their doctor tells them why they shouldn't get a partner. And there are some reasons, maybe other medical problems, maybe they don't want more medicine, but we know that adding the partner helps people to live longer and to feel better. So everyone should at least think about adding the partner. All right. So topic 2, genetic testing. Patients should ask about genetic testing. If they have a diagnosis of prostate cancer, they should ask about genetic testing and let their doctor tell them why or why not they should or should not have genetics done. And when I say genetic testing, it's important to know that there are 2 types of genetic testing. And there are lots of different tests that doctors may describe as genetic testing that are not necessarily actually genetic testing, but are really looking for panels and things that might inform their treatment choice, but are probably not genetic testing. So there are 2 types of real genetic testing. One type is called germline genetic testing. This is to understand the genetics that make up a person that they inherited, the genes, that DNA code that they inherited from their parents. Every one of us gets half of our genes from our mom and half of our genes from our dad. And that genetic code, that manual that tells your body how to be made and what to do, is called germline genetics. This is your DNA. It's inherited. It comes from your parents. If you have siblings or you have children, you share half of your DNA with your siblings and with your children. And you can test this by using saliva or a cheek swab or a blood draw, or sometimes with tumor testing if they're specifically looking for germline, but usually saliva, cheek swab, or blood. A different test that's still a genetic test, but is looking for different genes, is somatic testing. This is actually specifically looking at the genes of the cancer. Now, cancer cells, remember, start off as one of our own cells. They have the exact same DNA, the exact same genetic handbook that we all have, that each individual has. But a mutation happens, and another mutation happens, and a few more mutations happen, and they have a code book now that's a little different than the one that you inherited, that the rest of your cells have. And those mutations are what allow those cancer cells to be cancer, to live forever, to potentially move, and to grow somewhere they shouldn't be growing. That's what makes cancer. And those mutations allow them to do that. So this second type of genetic testing is looking for the mutations that have only happened in the cancer cell, that are not in the rest of your body. And so you need some cancer genetic information to find that to do that somatic testing. These develop over time. Like I said, they're not inherited. They're different from all the rest of the cells. They're not passed on to children. You don't share them with your family. They've only happened in your body in those cancer cells. You have to do testing that looks at the DNA of the cancer. That can be in a liquid biopsy that's looking at circulating tumor DNA. It can be in testing of the tumor tissue from a biopsy. It can be testing from tumor tissue from your prostate removal. So there are a couple ways you can do it, but this is a little bit different than germline testing. So who gets this? Well, this is the guidance that the doctors look at and try to make sense of who should be tested. This is what they're going to read if you ask them the question, should I get genetic testing? Here's the bottom line, just to be general so that you can have a sense when you go into that office if you should or should not get testing, but everyone can ask. For germline genetic testing, this is to understand what you may have inherited. Anybody with metastatic prostate cancer should get this. Anybody with high risk or very high risk prostate cancer that's still all in the prostate should get this. Anybody who's got a family history of multiple family members who have breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, and colon cancer should think about getting this. Why all these cancers, especially breast and ovarian? People who have ovarian cancer don't even have prostates. What does that have to do with it? Well, some of the same mutations cause prostate cancer that cause breast cancer and ovarian cancer and pancreatic cancer and colon cancer. And so if someone in your family has those cancers, you may be at higher risk to have those mutations in your body that might be the cause of the prostate cancer. So these are the general things. Other populations you should think about it, people with Ashkenazi Jewish heritage have high rates of some of these mutations and so also should be tested. And so there are some other things that somebody might have on the biopsy that might encourage them to think about doing testing. But it's important to ask, this is only for germline testing. If you're talking about somatic testing, testing for the cancer itself, that's going to be more centered on people who have metastatic prostate cancer. So what are we looking for? So in prostate cancer, the most common mutation is called BRCA2. It's the most common and it's the most responsive to treatment. That's a win because luckily the most common is also the most sensitive to treatment with PARP inhibitors. Here we can see, if we look at the line for BRCA2, we're going to find about half of those mutations in somatic testing that happen just in the tumor tissue, and about half of them in germline testing, which would be what we inherited. And when we put that all together, it's around 10% of people who will have this. Importantly, we have to do both of these tests to make sure that we aren't missing anybody who might benefit from one of these targeted treatments. Other mutations are listed here, and some of them, like the MSH2 and 6, all the way on the bottom, are things that we would actually target with a different medicine, a medicine called pembrolizumab, which is an immunotherapy. But if you ask for genetic testing, germline and somatic, you can think about getting all of these done because most of the modern tests have those at this point. What are PARP inhibitors? Why are we looking for these mutations in BRCA2, BRCA1, and other places? Because DNA is constantly getting damaged and it's being repaired by proteins in your body like PARP proteins. Because DNA has to be copied as cells are trying to replicate themselves, and because errors happen in cells just like they happen in our lives, there has to be a system that comes around and tries to fix these errors. PARP proteins repair errors. If the PARP proteins are inhibited, they can't repair errors. And when you have mutations in some of the genes that I just talked about, including the BRCA genes, you're going to be you're losing another backup system that's supposed to be repairing errors. So if you lose all of the backup systems that are supposed to be repairing errors, some because the mutations have happened in your body, and others because maybe you're using a medicine that blocks the proteins from doing their repair jobs, you actually have a buildup of mutations and the cells end up self-destructing because they don't have a way to repair themselves. They can't function. And so essentially what we do when we're trying to find these mutations and use PARP inhibitors to target them is to target a vulnerability and exploit it in the cells so the cells self-destruct. So in the last few years, and you can see these approvals came in 2020, but more recently, there are some new approvals, including discussions at ASCO 2025. We have had multiple PARP inhibitors approved by themselves. These two drugs were approved by themselves for people who have some of these mutations, olaparib and rucaparib. But we also have combinations of those drugs, olaparib, and not rucaparib, but olaparib, and some other PARP inhibitors, talazoparib and niraparib, with partner drugs that seem to make them stronger. And these partner drugs are actually hormone blocking medicines that we use even in other settings. For prostate cancer, we talked about them in combination for people with new metastatic prostate cancer, actually just a minute ago. Abiraterone is the drug that stops the adrenal glands from making testosterone. Enzalutamide is a drug that blocks the testosterone from getting into the cancer cell. And when used in combination with these PARP inhibitors, they tend to seem to prolong the time to cancer progressing in people who have these mutations and are vulnerable, and also help people live longer. So we know that the PARP inhibitors on their own look pretty good. When we pair them with the partner, they look even better. So we often are using them in these pairs now, and that's been in just the last couple of years. Thinking about PARP inhibitors, remember, they can cause side effects like low blood counts, fatigue, and some GI effects like nausea or decreased appetite. Usually these are pretty self-limited, but they do require us to do some blood work and check every month, usually at the beginning, to make sure that people are safe on these drugs. Pembrolizumab is an immune medicine that is targeting a certain vulnerability, again, in repairing these errors, but a different set of genes, PMS2, MSH, and MLH. And so it's important for this to also be tested when you're doing genetic testing, because it's an immunotherapy only for 2 to 4% of people with prostate cancer, but can be really, really helpful with a low side effect burden. So, conclusions on genetic testing: ask if you should get genetic testing. Germline testing is going to be related to your family. Somatic testing is related to the mutations in the cancer cells themselves, because this genetic testing may identify options for treatment. And germline testing may really inform your family members that maybe they need to get tested too. Siblings and children share 50% of your genes, and if you have a mutation, they should be tested to understand if they have a mutation. And if they have a mutation, their siblings and children should be tested to see if they have the mutation. It's called cascade testing, and it really centers on the person with the cancer and the mutation, and then goes out in waves for those family members that are most closely related. Somatic testing, testing the tumor tissue. This can also identify options for treatments, but has no implications for family. Somatic testing is really the understanding the mutations of the cancer, but not the person overall, and not inherited by family members. PARP inhibitors alone or in combination can improve the length of survival and help maintain people's quality of life. And pembrolizumab is an immunotherapy that can be an option for patients who have those certain mutations. It's just a low number, but it can be really helpful for them. Okay, radioligand therapy, let's dive in. These are therapies that are radioactive. You can see in this schematic on the right-hand side, the thing that's kind of like pink and blue with these little offshoots of blue lines coming out of it. That is to represent the radioactive particle in this diagram, a particle called lutetium-177. It gives off these radioactive waves that can travel pretty far and actually cause some low level of radiation to the people around the person getting treated, which is important to consider and talk about when you're in clinic and thinking about this therapy, just to ensure radiation safety. But that wears off within a couple of days. You can see the other half of that little symbol there, that little diagram, is a little molecule labeled, it's a purple molecule labeled PSMA 617. This is a small molecule or a small protein that is targeting a certain protein on the prostate cancer cell called PSMA. And it's expressed on prostate cancer cells. And when this little molecule gets into the system, it attaches to that protein. And if it's also attached to that radioactive lutetium-177 radioactive molecule, it basically is bringing that radioactivity directly onto the cell to let that radioactivity attack the cell and hopefully damage the DNA enough to kill the cell. The important thing about PSMA is it is not just a homing beacon for radioactive medicines to target to the cancer cell. It's also a homing beacon for our imaging agents. And these people, these patients that you can see imaged here, and these are images of people, you can see there's a lot of red spots on some of them. The red spots are areas where PSMA protein is being expressed on their cancer cells, and the imaging type of PSMA targeting agent is attaching to those cells and showing us as doctors looking at these scans exactly where the cancer cells are. And it's really helpful for us to have this because this imaging shows us exactly where that drug is going to go, and it can help us monitor people. So you can see in each of these panels, there are 2 pictures. One has a bunch of red spots on the left-hand side of each panel, and on the right-hand side of each panel, the same image looks like it has a far lower number of these spots. It's because these are before and after treatments for people who had the medicine I just showed you on that last slide, lutetium-177, PSMA 617. So its other name is Pluvicto. So when those patients were treated with a medicine that targeted that protein, it attacked, and then it actually, after several treatments, gave them a scan that looked vastly improved. So that's just to show that we can follow that treatment over time as well, which is important and helpful. So these are those survival curves again for this particular medicine, lutetium-177, PSMA 617, radioactive medicine, also called Pluvicto. On the left-hand side, you can see the darker blue curve is on the top of the light blue curve. The darker blue curve represents people who got the Pluvicto medicine in addition to standard of care treatment, And the lighter blue curve is just the standard of care treatment. And the Pluvicto treatment wins because it's higher up. And that's on the left-hand side, survival. People lived longer. And on the right-hand side, it's progression. Their cancer's growing on scans. So it did better in terms of helping people live longer. And on the right, it controlled the cancer and stopped it from having progression longer than the standard treatment. So for both of those, the Pluvicto won. And because of that, this medicine, lutetium 177, PSMA 617, again, also called Pluvicto, was FDA approved in patients in this trial. And all the patients in this trial had had one of those hormonal medicines like abiraterone, enzalutamide, apalutamide, or darolutamide, those extra pill hormone kind of blocking medicines, and they'd also had chemotherapy. So this drug was approved after those two treatments. A newer update in the last year has been the same study, but moving the Pluvicto medicine before chemotherapy. And in these slides on the left, you can see the proportion of patients in terms of the progression, the cancer growing on scans, showing that the treatment that's better is the blue line because it's higher up. Less cancer progressing in this setting when treated with the Pluvicto medicine than the control arm, which is in red. And on the right-hand side, you can see survivals overlapping basically. In this trial, after someone had the cancer growing on the control arm, they would actually get the Pluvicto medicine. And so they often had similar survival. But because of this benefit in controlling the cancer growth, the FDA has now approved this Pluvicto medicine before chemotherapy. So we can use it earlier. Now, one of the press releases that came out actually at ASCO was this complicated trial, which we don't need to go into the details, but it's essentially moving this Pluvicto medicine into that first metastatic stage that we talked about at the very beginning. New diagnosis, metastatic prostate cancer, first time it's spread. And the press release showed that the Pluvicto medicine seemed to improve progression and maybe has an appearance of possibly helping to improve survival when used even at that first diagnosis for metastatic cancer. We've only seen a press release. We don't have all the full information. We hope to get it soon, but it may be coming that Pluvicto is going to move even earlier in that treatment pathway. And the other radioactive medicine that we had a very recent update on, including at ASCO, was a medicine called radium-223. This medicine, Xofigo is its other name, has been around for a long time, over a decade. But this new study showed that if we add that to enzalutamide, which is a hormone blocking pill, we can do even better than just using enzalutamide alone. And so that was presented a few months ago, well, almost a year ago at ESMO, and then updates were presented at ASCO this year. It not only helped to prolong the time for the cancer to grow, but it also helped people to live longer, quite a bit longer, in this particular trial that was just reported, a European trial. So let's sum it all up. So PET scans can be used to identify patients for treatment with Pluvicto, that lutetium 177 PSMA 617 medicine. We can see the PET scans targeting the same protein. It allows us to see where that medicine may go. The use of Pluvicto can be before or after chemotherapy now because of those curves showing that they separate and the Pluvicto was always on the top. Ongoing studies are trying to help us to see if we move it even into first diagnosis of metastatic disease. Could it be more helpful? We'll hopefully see data very soon. We just have a press release. And radium-223 might be helpful, also called Xofigo. If you're getting treatment with enzalutamide, maybe you can use radium, and that'll also improve the activity of the enzalutamide. And there are lots of new agents that are being studied for these radioligand treatments that are being developed. And I know that was a long time to talk. I'm going to stop sharing and take some questions. Again, sorry for such a data dump on everybody and also for my dog and child, but happy to take questions.
Well, thank you so much, Dr. Morgan's great information. And I appreciate even things like the slides showing how to read a, survival plot. So I think that's really important for our viewers. So we have lots of questions, as you know. You covered some of these, which is great. So, but I am gonna, since you just ended with talking about lutetium, I'm gonna kind of, I I think it's maybe another, it's related, it's somewhat related to this. So um this question is, are actinium treatments good? And maybe you can talk a little bit about that, what that is. Good for treating prostate cancer if this person has successfully completed Pluvicto treatment. They're just trying to get ahead and thinking, they're in remission now, but want to know more about other treatments that could be possible if their cancer comes back.
Sure. So actinium is one of many different radioactive medicines that are being investigated for use either after Pluvicto or even before. And there are multiple trials that are investigating just that. It's a little bit of a different type of radioactivity. It causes a bigger explosion of radioactivity, but it doesn't travel as far. It's more kind of localized into the cell. And so it has that's a plus and a minus, depending on what you're dealing with. But it is absolutely being developed. So if it is something that somebody needs right now, there are trials that are launching across the country to be able to investigate and possibly consider getting into a trial. If it's something you might need in the future, then hopefully the trials will come out and be able to tell us. We don't know right now if it is going to be the blockbuster benefit that we think we see with Pluvicto in terms of having many people seem to benefit and the ability to kind of target that radioactivity really both to the bone and to soft tissue to allow really a benefit across many different patient types. But we're hopeful. And there is a suggestion that it will be beneficial. We just don't know yet, and we're evaluating it to figure it out. But also know copper, lead, terbium. There are multiple other radioactive medicines that are being developed. And I just named the elements. The medicines are going to be a combination of the element plus the targeting component. So lutetium, we just called Pluvicto lutetium, but lutetium is actually just the radioactive component. There are multiple other trials that have the same radioactive medicine, but a different targeting molecule. Those you might see being available at some point relatively soon as well. So it's just getting more complicated, but that means more options for patients. And actinium is one that I'm hopeful will be an option and may be effective for people.
Sounds good. We're waiting on the data. How does the velocity of spread of metastases and PSA doubling affect treatment decisions for low volume, high volume, and oligometastatic disease? And if you can define oligometastatic disease, just in case people aren't familiar.
Sure. So low volume being a small amount of metastatic cancer, high volume being a high amount, and oligometastatic being an extra small amount, usually 5 spots or less of cancer spread outside of the prostate. Um, PSA doubling time does not typically come into the consideration. The rap if it's a new diagnosis of metastatic disease, it's often not something that we understand the trajectory of very well. So the how rapid its spread isn't necessarily going to be defined, and it may not be helpful. But the more rapid it spreads, the more likely it is to be aggressive. The more likely it is maybe to be high volume. The things that remember that we talked about being aggressive markers of aggression. Metastatic at first diagnosis and high volume disease are considered sort of markers of aggression. They're also molecular markers, meaning when we do that genetic test, there are some things that we can't target, but we know are associated with aggressiveness, like P10, P53, and RB, just some mutations that we look for. So we often look for de novo metastatic, high volume, and then some of these mutations to define aggressiveness. But we're not really using PSA doubling time or the time for metastatic disease as much in that kind of an assessment.
Great, thank you. And you touched on this too, and I think it's a good question. Is there any research being done to determine if the effect of testosterone on prostate cancer growth can be blocked without eliminating the testosterone itself?
Yeah, I think that there's definitely research investigating this right now because no one wants to lower testosterone in the whole system if we only need to block it from getting into the cancer cells. So it's an area of interest and investigation, and to be determined. But probably we will have a day in the future where we can say, okay, we can block this cancer cell without lowering your testosterone.
Okay, sounds good.
Let's
What?
talk about here's a question, Jeremy. There's a
Yeah.
question about somebody's got surgery upcoming. So if you're kind of a newer diagnosis, you've got surgery upcoming, what can you do? I would strongly recommend you think about Kegel exercises. This is an often overlooked consideration. What is a Kegel exercise? It's an exercise to strengthen your pelvic floor, the muscles that wrap around the bottom of you. When you have your prostate removed, often that disturbs the valve or the closure that sits inside the tube that leads from the bladder out through the penis, the urethra. That valve keeps you dry. It holds the urine in when you want it to be in, and it opens up when you want to urinate. The valve gets disturbed when you take out the prostate because it's sitting right against the prostate. What do you do when you don't have a valve? You leak your urine, unless you train your pelvic floor muscles to squeeze tight on that urethra and hold the urine in, just like the valve used to do. So if you do your Kegel exercises, you're retraining those muscles, and you're getting that strength and control back to close off the urine flow. And the most, I could not be more emphatic. Take the time to do Kegel exercises. If you have a woman in your life who has had a baby, they may know what a Kegel exercise is, because these are exercises that women do after babies, stretch out their entire pelvis to get that strength and help them from leaking urine. And this can be something that can be really helpful for you as you prepare for surgery. And then after surgery, do those exercises, get that urinary control back.
Oh, that's great. That's great advice. And I think those are things like that can be done at home. It can help also to see a pelvic floor specialist if
Absolutely.
that's of interest, to get you started and make sure you're doing them right and that type of thing. They can help prepare. So
Great advice,
great.
Jeremy.
Yeah, no, it's great to do that before, as you suggested. It's often, suggested afterwards, but doing it before will help. So, yeah, great advice. Well, we're at time. So thank you so much for your time here, presenting such great information and answering our questions. It was a really informative discussion. So thanks so much, Dr. Morgans, once again, as always. As we close today's webinar, we want to remind you to please fill out our short survey that's being shared in the comment box now in the chat box, and to look out for an email with the recording in case you'd like to share it or listen again. Thank you for joining us all for this important discussion, and I hope you have a great evening. Thank you again, Dr. Morgans.
Thank you, everybody.